A couple things to remember of the overall function of the immune system. We're going to go over key points here. Immune system requires the interaction of immunity and inflammation working together to control infection. Skin mucous membranes, and white blood cells are the main components of a person's immunity. Immunocompetent means a couple things to remember of the overall function of the immune system. We're going to go over key points here. Immune system requires the interaction of immunity and inflammation working together to control infection. Skin mucous membranes, and white blood cells are the main components of a person's immunity. Immunocompetent. A person's immune system is able to recognize self cells versus non-self cells. Each cell is surrounded by plasma with different proteins. Each person's cells have a unique surface protein that are specific to that person, known as human leukocyte antigens. Immunity changes during an adult's life as a result of nutrition status, environmental conditions, drug, diseases, and increased age. A person's immune system is most efficient in their 20s and 30s and slowly declines with age. Most immune system cells come from the bone marrow. White blood cells, or leukocytes, are immune system cells and have a variety of actions. Page 292 in your book discusses the specific functions of leukocytes, such as neutrophil, macrophage, monocyte, eosinophil, basophil, B lymphocyte, plasma cell, memory cell, helper-induced T cell, cytotoxic T cell, and natural killer cell. The role of the leukocyte is recognition of self versus non-self. The presence of foreign invaders, getting rid of cellular debris and unhealthy cells. It also is used for production of antibodies, activation, and stimulates increased formation of leukocytes in the bone marrow. General immunity is equal to a patient's natural immunity. This occurs with inflammation. General immunity provides immediate protection against the effects of tissue integrity and invading proteins. It provides inflammation, but it is only short term. It is nonspecific and can be started by any event. Example of this would be inflammation of scald burns or inflammation of swimmer's ear. Those are all types of general immunity. Leukocytes include neutrophils, macrophages, eosinophils, and basophils. They are included in the key process of inflammation. Phagocytosis is the process of engulfing and destruction of invading cells. Inflammation alone cannot provide long-lasting immunity. It is a short-term fix. Lymphocytes are needed for long-lasting antibody-mediated immunity. Specific immunity is an adaptive protection, long-term resistance to invading microorganisms. The response is not automatic, it is an acquired immunity. Lymphocytes develop actions that provide the immunity. Lymphocytes are produced in the bone marrow and migrate to lymphoid tissue, where they remain dormant until they need to form sensitized lymphocytes for cellular immunity or antibodies for humoral immunity. So if a patient has an infection and you are feeling tender lymph nodes, that's an indication that there's some type of infection and that the body has activated the immune response. B lymphocytes produce antibodies to a specific protein. The antibodies is what actually causes the reaction of elimination, neutralization, or destroy the foreign protein, also known as the antigen. B cells have the most direct role. Macrophages and T cells work with the antibodies to start and complete the antigen-antibody reaction. Page 296 in your book, Figure 17.8, 7 steps for specific antibody production against a specific antigen is a helpful resource and a visual tool. In antibody-mediated immunity, the body learns to make enough of any specific antibody to provide long-lasting immunity against specific organisms. First exposure or invasion of antigen, the body is able to generate antibodies, causing antigen recognition. This occurs by unsensitized B cells, macrophages, and T cells. Sensitization occurs when B cells recognize antigen as non-self and is now sensitized to that specific antigen. Antibody production is when antibodies search out specific antigens. Antibody binding action is triggered when an antibody binds to an antigen, causing destruction of the antigen. Then, finally, sustained immunity occurs. This provides long-lasting true immunity to a specific antigen. All antibodies are also called immunoglobulins. First exposure to an antigen, IgM, is produced by newly sensitized B cells. IgM is unique in that it forms itself into a 5-member group with 10 antigen binding sites. Table 17.3 in your book, page 298, goes over the 5 different types of antibodies and their specific functions. This process allows for illnesses to only last 5 to 10 days. Natural immunity occurs when an antigen enters your body naturally without human assistance and your body responds by actively making antibodies. An example with this would be the common cold. Natural active immunity is most effective and is the most longest acting. Artificial active is protection developed by vaccination or immunization. Small amounts of antigen are placed in a vaccine into your body. Your immune system then responds by activating and making more antibodies. Cellular-mediated immunity is an adaptive or acquired true immunity that is provided by lymphocyte stem cells that mature in the lymphoid tissue. Cellular-mediated immunity involves many white blood cells. Specifically, the T cells play a significant role in the fight for decreasing infection. T cells have a variety of subsets, each of which has specific functions marked by marker proteins. Helper-induced T cells recognize self cells versus non-self cells. They secrete cytoxins that increase immune function. Suppressor T cells prevent hypersensitivity, prevents antibodies from attacking healthy cells. Cytotoxic T cells destroy cells that contain a processed antigen. Natural killer cells conduct seek and destroy missions to eliminate non-self cells. Cytokines act as messengers that tell specific cells how and when to respond. Cytokines control many inflammatory and immune responses. When a patient has an autoimmune disorder, the usual protective nature of the immune system does not function properly. The body is unable to recognize its own healthy cells as part of self. It affects multiple areas of the body. Common diseases include rheumatoid arthritis, systemic lupus erythematosus, and systemic sclerosis. These connective tissue diseases are most characterized by chronic pain and joint deterioration, decreased function, and impaired mobility. This causes an increased economic cost to patients and healthcare systems. Care management includes therapies of medicine, nursing, rehabilitation, pharmacy, and case management. Osteoarthritis is the most common arthritis and a major cause of disability among adults in the U.S. and in the world. As cartilage and the bone beneath the cartilage begin to erode, the joint space narrows and osteophytes, or bone spurs, form. Osteoarthritis is a degenerative joint disease with local manifestations such as local joint pain. Osteoarthritis occurs more often in older women. Age and gender are important factors for a nursing history. Note the patient's occupation, nature of work, any history of injury, including falls, weight history, and current or previous involvement in sports. History of obesity is significant for presence of osteoarthritis. A typical patient with osteoarthritis is a middle-aged or older woman who reports chronic joint pain and stiffness. As people age or experience joint injury, proteoglycans and water decrease in the joint. The production of synovial fluid, which provides joint lubrication and nutrition, also declines because of the decrease of hyaluronic acid and less body fluid in the older adult. These synthetic joint fluid implants replace or supplement the body's natural hyaluronic acid, which is broken down by inflammation and aging. How does the decreased joint fluid affect exercise? It causes pain upon movement, which prevents immobility of joint. Weight-bearing exercises plays a very important role in stimulating regeneration of cartilage, which lacks blood vessels, by driving the synovial fluid through the joint cartilage. Joint mobility is increased by weight-bearing exercises, not by range of motion exercises. This is because surrounding muscles, ligaments, and tendons are then strengthened with weight-bearing exercises. Pain is an early sign of degenerative joint bone problems. Swelling may not occur for some time after pain, if at all. Osteoarthritic pain is worsened in cold, damp weather. Therefore, exercising outdoors is not recommended year-round in all settings. Obesity is a common contributing factor to osteoarthritis. Weight-bearing joints such as hips and knees are most often affected in obese people. As well as a physical assessment, assessing the psychosocial aspect of the patient is important as well. Severe pain may cause disability and immobility, which can lead to depression and anxiety and feelings of isolation. MRI and CT scans are common diagnostic tests to assess the presence of osteoarthritis. Osteoarthritis is a chronic condition that can cause many permanent changes in lifestyle. If acetaminophen or topical agents do not relieve pain, the analgesic drug class of choice is NSAIDs, non-steroidal anti-inflammatory drugs. Before beginning any oral NSAID therapy, obtain baseline laboratory information, including a complete blood count, kidney, and liver function test. When taking ibuprofen, encourage your patient to take after meals to minimize gastric mucosal irritation. Chronic use of NSAIDs has severe side effects, including GI bleeding and acute kidney failure. Therefore, they are prescribed at the lowest effective dose for a short period of time. The most common surgical procedure performed for older adults with osteoarthritis is total joint arthroplasty, also known as total joint replacement. Almost any synovial joint of the body can be replaced with a prosthetic system that consists of at least two parts, one for each joint surface. Total joint replacements are expected to increase as baby boomers age over the next 20 years. Arthroscopy is when an endoscope is inserted through an incision near the joint, such as a knee. It's a visual exam and used to diagnose and treat the interior of a joint. Osteotomy is the removal of a piece of bone or cutting out of the bone. Prevention of complications post-surgery includes preventing hip dislocation. Interventions include positioning correctly, keep legs slightly abducted for a posterior surgical approach, prevent hip flexion beyond 90 degrees, prevent hip hyperextension, assess for acute pain, rotation, and extremity shortening, perform frequent neurovascular assessments, report dislocation immediately to the surgeon. For preventing infection, use aseptic technique for wound care and emptying of drains. Culture drainage fluid if needed. Monitor temperature. Report any excessive inflammation or drainage to surgeon. For venous thromboembolism, have patient wear elastic stockings and/or sequential compression device per agency policy. Encourage oral fluid intake. Observe for signs of deep vein thrombosis. Observe patient for changes in mental status. Administer anticoagulants as needed. Do not massage legs. Do not flex knees for a prolonged period of time. Although many adults require total knee arthroplasty, those who have had a knee replaced are often younger than those who have a hip replaced. An increasing number of patients who have a total knee replacement are overweight or obese. Some surgeons prescribe a continuous passive motion machine after knee surgery to increase joint mobility. When caring for a patient receiving continuous passive motion machine, perform neurovascular assessments every 2 to 4 hours or according to hospital policy. The patient should be able to plantar flex and dorsiflex the affected foot, but not feel pain in the lower leg. Check for movement, sensation, warmth, color, pulses, and capillary refill. If your patient experiences numbness, contact your physician immediately. The nurse should suspect nerve damage if numbness is present. However, whether the damage is short-term and related to edema or long-term and related to permanent nerve damage would not be clear at this point. The nurse needs to continue to assess the client's neurovascular status, including pain, pallor, pulselessness, paresthesia, and paralysis. Bleeding would suggest vascular damage or hemorrhage. Discoloration would suggest malignment. Pink color would suggest adequate circulation to the area. Numbness would suggest neurologic damage. In rheumatoid arthritis, transform autoantibodies attack healthy tissue, causing inflammation. The disease then causes damage to cartilage, joint, capsule, and surrounding ligaments and tendons. In late stages, abnormal fusions of bones occur, calcification occurs, bone loss density, and osteoporosis. Early and aggressive treatment is key. It is more common than women and than men. Key signs and symptoms of rheumatoid arthritis include inflammation, low-grade fever, fatigue, weakness, anorexia, and paresthesia. Early signs and symptoms of rheumatoid arthritis include joint inflammation, generalized weakness and fatigue, anorexia, persistent low-grade fever. Joint pain of upper extremity is most commonly reported first. Late signs and symptoms include very painful joints, stiffness, soft spongy joints, muscle atrophy, and decreased range of motion. Joint deformity, subcutaneous nodules on arms and ankles may also be present. Organ malfunction can occur if inflammation of blood vessels occur. Peripheral neuropathy, respiratory complications can lead to pneumonia. Several syndromes are seen in patients with advanced RA. A significant one seen is called Sjögren's syndrome. This is characterized by dry eyes, dry mouth, and dry vagina. If your patient has Sjögren's syndrome, assess for open mouth sores, provide water-soluble lubricants, artificial tears, and a room humidifier. Rheumatoid arthritis can cause disability, frustration, loss of independence, altered body image, depression. These are all common. Evaluate patient's resources and support system. The test for rheumatoid factor measures the presence of unusual antibodies of the immunoglobulins G and M, types that develop in a number of connective tissue diseases. Many patients with RA have a positive titer greater than 80, especially in older adults. However, the presence of RF, rheumatoid factor, is not diagnostic alone for rheumatoid arthritis. An elevated erythrocyte sedimentation rate, or SED rate, can confirm inflammation or infection anywhere in the body. An elevated ESR helps support a diagnosis of an unspecified inflammatory disease. The test is most useful to monitor the course of a disease, especially for inflammatory autoimmune diseases. In general, the more severe the disease gets, the higher the ESR rises. As the disease improves or goes into remission, the ESR level decreases. The presence of most chronic diseases, including rheumatoid arthritis, usually causes mild to moderate anemia, causing easily fatigued patients. This is due because the production of erythropoietin is compromised. Monitor the patient's CBC and assess for low hemoglobin, hematocrit, and red blood cell production. An increase in white blood cells is common. The goal of medication therapy is for the patient to have an acceptable pain level. Non-steroidal anti-inflammatory drugs are common use. Instruct the patient to take an NSAID with an H2 blocker such as Zantac to decrease GI problems. Methotrexate is a first-line therapy. It is an immunosuppressant medication. It is effective and relatively inexpensive. Teach your patient that it takes 4 to 6 weeks for patients to work, but do not get pregnant while on methotrexate. It also suppresses the patient's immune system, so teach patients to avoid crowds, and especially during flu season. Cortisone and glucocorticoids are injections that can be put into joints that can be used to relieve pain. Teach patients to rest the extremity in ice after the procedure. Glucocorticoids, usually prednisone, is given. It's fast-acting. Chronic use can result in complications such as diabetes mellitus, decrease in immunity, hypertension, and osteoporosis. Non-pharmacological methods are also successful in relieving pain and discomfort for your RA patient. Encourage your patient to stay consistent in exercise programs to keep joints loose and mobile. Avoid weight bearing on inflamed joints. Apply heat or cold therapy as prescribed to joints. Ice helps hot spots or alleviates pain. Teach your patient to not use ice for more than 10 to 15 minutes at a time. And make sure the ice pack is not too heavy on your joint. Typically, an ice pack about the size of a bag of peas is a good size. Heat helps loosen up the joints, but it should be noted that heat-producing liniments cannot be used with other heat devices such as a heating pad at the same time. Also teach your patient to balance rest and activity and to take frequent breaks as needed. The expected outcome for an RA patient is for the patient to be independently able to perform their activities of daily living. Assess the need for assistive devices, work with occupational and healthcare provider, instruct client in alternative strategies to provide activities of daily living, instruct in energy conservation measures, instruct your patient to take frequent breaks. Also note that iron supplements may be prescribed for patients with anemia. If chronic NSAID use is in progress, assess for GI bleeds in stools, gums, and any type of bloody vomiting. Teach patients to pace activities, allow rest periods, set priorities, and obtain assistive devices when needed. Occupational therapy can provide equipment for daily living. Encourage moderate increase in activity to preserve motor function during periods of less inflammation periods.